You got this.
Okay. Cool, thank you. Okay. Hi, everyone. I'm back. My name is Destiny, and our presentation is on erectile dysfunction. So erectile dysfunction, also known as ED, is a prevalent and multifaceted condition that mostly affects males beyond 40 years, but the prevalence is rising globally. It's characterized by the consistent or recurrent inability to attain and maintain an erection that's sufficient for sexual performance. ED is diverse as there's many causes of it, and so it's really important to understand those different causes so that you can choose the right treatment. There's organic causes, psychogenic causes, and then mixed factors, often influenced by things like diabetes or cardiovascular disease or neurological disorders. Some of the common causes are vascular causes like hypertension, hormonal causes like low testosterone, medications like antidepressants, especially SSRIs or SNRIs, as well as neurological causes like spinal cord injury, stroke, and Parkinson's disease. There's also psychogenic causes like performance anxiety, depression, relationship issues, structural causes like congenital abnormalities or penile traumas. There's also lifestyle factors to consider like obesity, poor diet, excessive alcohol use, smoking, etc., as well as aging and just a natural decline in the ability to maintain an erection. In terms of a systemic assessment, when you're working with someone who maybe is struggling with this, it would involve a multi-step approach to identify the underlying causes that's impacting the client's health as well as their relationships. So you would want to do a comprehensive history, kind of clarify what's going on, and if there's any other sexual issues like low libido, as well as using maybe some questionnaires, to kind of assess where they're landing. You would also want to do a physical examination. So checking for blood pressure, heart rate, body habits, things like that, as well as routine blood tests, looking for, maybe signs of diabetes, uh, fasting, blood count, all of that kind of stuff. And then a cardiovascular risk assessment to assess for fitness for sexual activity. And then also a psychosocial and relationship assessment to kind of explore any psychological factors that are happening, like anxiety or depression, as well as how this is impacting their partner, and kind of assess how it affects both of them, and what their expectations for treatment is.
Hi everyone, I'm Hilda. I will be talking about diagnosis as well as biological considerations. So ED is defined as a consistent or recurrent inability of a man to attain or maintain penile erection sufficient for sexual activity. The condition does have to be present for at least 3 months. And as Destiny previously mentioned, to be able to diagnose ED, a thorough assessment is needed. And the information that needs to be gathered is the onset of ED, correlation with a specific partner, any couple conflicts, as well as erection/rigidity. And as mentioned previously, this can be done through specific questionnaires, one of them being the International Index of Erectile Function. And there are degrees of impairment, such as mild, moderate, or severe. And it's important to note that ED is part of a spectrum which encompasses sexual interest, early ejaculation, delayed ejaculation, as well as orgasmic dysfunction. I think it's really important to note as well that erectile disorder is different, it's separate. This is a formal psychiatric diagnosis found in the DSM. So erectile dysfunction, as mentioned in the previous slide, is a broader medical term often used in primary care. And the key difference between erectile dysfunction and erectile disorder is that erectile disorder, which is recognized in the DSM, requires a minimum of a 6-month duration versus only 3 months for erectile dysfunction. And for the diagnosis, the distress component does need to be there, as well as exclusion of any other causes. For erectile disorder, according to the DSM, a diagnosis includes a marked difficulty in obtaining or maintaining an erection during sexual activity, or a marked decrease in erectile rigidity, and this has to occur at least 75% of sexual occasions for sexual activity. Symptoms do have to persist for a minimum duration of 6 months, and it must cause clinical significant distress in the individual. And then it also cannot be better explained by a non-sexual mental disorder such as MDD, severe relationship distress, or other significant stressors or effects of a substance or medication. For biological considerations, some of these things were already brought up, but things like vascular issues, neurological causes, hormonal imbalances, chronic illness, medication and substances, as well as age-related decline, which is the most common. So for vascular issues, things like high blood pressure, high cholesterol, which reduces blood flow. For neurological causes, any nerve damage from diabetes, stroke, or spinal cord injuries. For hormonal imbalances, low testosterone does equate to reduced libido and erectile ability. For chronic illnesses, things like diabetes, kidney, and liver disease, which affects nerves, hormones, and circulation. And then for medications and substances, which was previously mentioned, things like antidepressants, antipsychotics, these can all impair sexual function, as well as smoking, alcohol, recreational drugs. These all contribute to ED.
Hi, my name is Madeline, and I will be talking a little bit more about the types of treatment, the research, and some diversity factors to pay attention to with ED. Always with the onset of erectile dysfunction, the initial treatment is going to be looking at where your health status is and how just small lifestyle modifications can improve erectile dysfunction. So this not only improves erectile function, but reduces cardiovascular risk because there is a direct attachment between these two disorders. The lifestyle modifications would be things like increased physical activity, switching to a Mediterranean diet or nutritional counseling, stopping smoking, drugs, and alcohol, and gaining reasonable control of diabetes, lipids, and cholesterol. So these physical effects or these physical modifications have a really positive effect on improving ED and improving the prognosis as well. The prognosis, however, is dependent on the cause. So psychosexual causes generally have a good response to counseling, and most other causes of ED respond well to oral medications. If not, there are multiple other options for treatment, like external vacuum devices, intraurethral prostaglandin pellets, intracavernosal injections, and combined therapy. Patients rarely fail all of these non-surgical options. There are still penile prosthesis implantation surgeries, which remain highly successful, and almost every patient with ED can be treated successfully with the current available therapies. Again, it is important to note here that typically a combined treatment, a sort of interdisciplinary approach, is the most effective and has the best prognosis. So combining increased physical activity with psychosexual counseling would be probably the best way to begin tackling the issue of erectile dysfunction. As far as current research, another sort of treatment alternative is shockwave therapy, which sort of gained traction in 2010. And research from 2025 shows that monthly shockwave therapy in men with ED who do not have comorbidities, so multiple diagnoses, was more effective over 6 months than weekly treatments over 6 months. Results showed that erectile hardness, self-esteem, and clinical improvement were benefited from these shockwave treatments. And as I mentioned, this treatment gained efficacy in 2010, And this recent study shows a prolonged effectiveness over the 12 and 24-week follow-up appointments. For men who are suffering a long bout of erectile dysfunction, shockwave therapy alongside psychotherapeutic interventions are recommended, because this research study did have the patients in therapy while they were in shockwave therapy. So they were doing talk therapy intermittently. Now, one of the common misconceptions of erectile dysfunction is that it has a cause or etiology within porn and masturbation. And an article that was released in 2023 shows that, or this 2019 study, 2023 article, proves that there is little to no correlation between porn and erectile dysfunction, and a mild association to be found between high masturbation frequency and um, and ED. There is no causality between these variables in ED. However, further research ought to be established on porn addiction and erectile dysfunction. Variables along the line of self-esteem, relationship satisfaction, mental health, and sexual trauma are much more established as causing erectile dysfunction. And overall, creating a healthy balance of porn, masturbation, and intercourse is recommended alongside these other health effects that we discussed. As far as diversity and multicultural considerations, there can be myriad etiology for this disorder, and interviewing a couple that is struggling with ED, all aspects of the client's life, including their social location, history, satisfaction with life, and personal measures of pleasure in sex ought to be given attention. As we were doing some research, we found that underrepresented populations like Hispanic, Black, and Asian clients are less likely to be forthcoming about suffering from ED, and they also receive disproportionate treatment. Now, we've talked about the relationship between cardiovascular disease and ED, and this does lead to the statistic that men in lower socioeconomic statuses have a higher likelihood of developing ED and then heart disease due to the impact of stress from being in a lower socioeconomic status and that impact of stress on heart disease. Now, additionally, Black and Latino men are more likely to be recommended surgery for treatment of ED, while white patients are more likely to receive prescription medication or be referred to psychotherapy. As we were discussing treatment, obviously surgery is the last thing that we want to turn to. Surgery is something that can be incredibly invasive, painful, and just generally unnecessary for ED. So the fact that these populations are receiving this treatment plan is not good, and it's something to look out for as therapists, honestly, when we are referring our male clients of underrepresented populations to medical care for erectile dysfunction. Overall, diversifying the clinical trial staff, holding clinicians accountable for learning about these statistically proven biases, and recognizing the relationship between a lower socioeconomic status in ED and cardiovascular disease will mobilize the community to begin treating all populations equitably. Thank you so much. Here are our references, and we appreciate you listening to our presentation.